Okay, ma'am. So we are live now and I'm starting. Very good afternoon and warm welcome to all the dignitaries present here. I am Momita from Clanet, serving as the allocated station assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform offering a multitude of enriching services exclusively for doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by National Neonatology Forum Gujarat, and the focus of today's session is the POCUS Series 13 Basic Pathophysiology of Shock. So, without any further delay, let's begin today's session, for which I would like to invite Dr. Shwetal Bhatt, ma'am, to take over. Over to you, ma'am.
Thank you. Uh, Today, I would like to thank Dr. Mohit sir for NNF Gujarat is really obliged to have your POCUS series, and for the neonatal Pathshala, I am really glad that in very without any excuse, every month we are having this POCUS series. Thank you so much, Dr. Mohit sir. And on this platform, we are having international and national participants because of your famous POCUS series. Thank you so much, sir. I would like to ask Dr. Urvi to introduce sir and moderate the session.
Yeah. Good afternoon, all. I'm Dr. Urvi Sanghvi from Rajkot. I would like to introduce today's our speaker, Dr. Mohit Sani from Surat. He's a very senior neonatologist from Surat and an expert in newborn ultrasound. I request sir to please start the session on basic pathophysiology of shock. Mohit sir. I think sir has joined, but
Mohit sir, are you there?
I think sir is maybe arranging the two devices
maybe.
because one device he takes to NICU and the other device he... Just we can wait for sir to... He must be arranging the device, or I can exit and I'll call him. Just a minute.
You can, ma'am, be online only, and then you call it. It will automatically pause your video, ma'am.
Okay, okay.
Just mute and do it now. It will be fine. Actually, I tried to call him, but he's not picking up.
Sorry, I wasn't stuck with some patient. Hello, good evening.
Good afternoon, sir. Welcome, sir.
Sorry.
Sir has joined.
I got stuck with some patient.
Good afternoon, sir.
Good afternoon.
Welcome, sir.
Sir, volume.
Yeah, volume now is okay?
Yes.
Yes.
Okay, I'll just repeat once. Good afternoon and welcome, Mohit sir from Surat. He's one of the pioneers and expert all over the world, international faculty for ultrasound. And I'm not wasting now much time. I request Mohit sir to start on basic pathophysiology of shock. Over to you, sir.
Everyone, thanks Gujarat NNF, Dr. Kanal, Dr. Urvi, Dr. Shwetal Madam for continuing this series. And we have started with the shock. Soon, like in shock, there will be interesting discussions and everything we will be holding on this platform. So today we will just stick to pathophysiology. What is the basic pathophysiology, because of which we should understand that pathophysiology, and hence we use that knowledge to treat the shock appropriately. When we will move on to the treatment part, we will see that how blindly we have been treating shock, and if we understand the pathophysiology well, so how appropriately we can treat the shock. So it is more of a pathophysiological discussion that we'll be doing today. So I'm sharing my slides. Everyone is able to see my slides?
Yes, sir, but full screen you need
Yeah,
to make.
I'm doing so.
Yes, sir, visible now.
So, as we have discussed that pathophysiology, to understand pathophysiology, it is very important. And again, I don't know, Dr. Kunal, the participants
Yes, sir.
cannot unmute and talk. Na? They can write in the chat box.
Sir, they can unmute
They can unmute and talk.
if you. Yeah, yes, sir. Yes, sir.
Okay.
And still, if you require, sir, you can ask the ClearNet coordinator. She will help you with that, sir.
Okay.
Momita is there, sir, if you need any help.
So there in the settings, they have not opened up the polls. Okay, fine. That's fine. So this is a question to start with. All the participants who have been there with us, thanks for joining in. If you people are talk about shock, this is one thing I would like to know from you people, like what, when you assess shock, what you assess first. As soon as the shock, baby with the shock comes, what you people assess, you can write in the chat box or you can unmute and talk. Anyone? What are the things you would like to assess whenever you assess a baby with a shock? So there is something in the chat box. CRT, okay. Capillary refill time, heart rate, peripheries, heart rate, pulse volume, peripheries, temperature, respiratory rate, heart rate. Fine, great, good. So why you people assess the capillary refill time? Why you people assess pulses? Why you people assess? Yeah. So there is answer, pulse volume. Okay. Why you assess pulse volume? What is the main idea behind assessing the pulse volume? Okay. The other thing, the other way around, if I reframe this question, what are, okay, sufficient cardiac output? Great. Cardiac output. Good. So the cardiac output is what? What is cardiac output? How we get the cardiac output? So what is cardiac output actually formed? Like what is, it's a product of what?
Stroke volume and rate.
Pardon?
Stroke volume and heart rate.
Stroke volume and heart rate. Great. And what is stroke volume formed of? How the stroke volume is formed? Preload. Great. So that means if you want to classify shock, how you will classify the shock? See, everybody is giving very appropriate answers. Very nice. Preload SVR, yes. So preload SVR. So if I broadly want to classify the shock, how I would classify the shock? Okay. Now let me go there. These are the things I was just thinking to like preload, you have answered preload. Afterload is what? Most of you have been writing SVR, systemic vascular resistance. And the other one thing I need to do is contractility. You imagine yourself that preload is the money in your bank account. Contractility is your capacity to how much you can spend. So this is husband, me. This is me, husband. This is the capacity that how much I can spend. Preload is the amount of money in my bank account, and afterload is my wife. Even if I have a preload, appropriate bank money, I have the capacity to spend. But if my wife does not allow me to spend, then everything is in futile. I cannot spend that money. Or if I have appropriate amount of money and my wife is idealistic while in the ideal world, so she allows me to spend, but if I cannot spend, even then the money will remain here, will not go ahead. So that means for me to spend appropriate amount of money, all these things should go hand in hand, that I should have an appropriate amount of money, I should be able to spend, and I should not get any resistance from my wife to spend. So that means for your idealistic cardiovascular performance, for appropriate cardiac output, I should have appropriate amount of preload, that is appropriate amount of blood should be there in the vessels. My cardiac contractility should be appropriate, and afterload should be appropriate to allow that amount of blood to be pumped out of the heart. So these three things are in majority that actually rules or maintain your cardiac outputs and your tissue perfusions. So we should assess the baby under these three gross headings to assess whether the preload is good, okay, the intravascular volume is good. Then we should know and assess how much is the cardiac contractility, so that we can choose our drugs appropriately to treat that shock. So that's why all the shocks, whenever we talk about and whenever we will assess, will be under these three broad headings: preload, contractility, and the afterload. I hope that answers the question that I asked, and indirectly, most of you have answered it correctly. So now we will come down to the few of the major causes that cause shock in the newborn babies, that make them unstable or hemodynamically unstable. So one, the most important, and that too in the premature baby, is the immature myocardium. So inherently, there is a dysfunction of the myocardium, especially in the preterm babies, and that too, especially the diastolic dysfunction. And we will see in the further slides in further presentation that we will discuss that the peripheral vascular resistance is very immature. Like we will discuss that when we talk about compensation, one of the important part of compensation for the shock by the body is by increasing the peripheral vascular resistance, which is not very great in newborns and especially in the preterm babies. Another issue is the PDA, patent ductus arteriosus. Sepsis, as we all know, is a big cause and a major cause in all over the age groups: preterm, term, infants, pediatric patients, adults, everywhere. Then, especially in the newborns, hypoxia, PPHN, birth asphyxia, meconium aspiration syndrome is another a major cause. Nowadays, even though the incidence is coming down, but still it is a cause for the shock, for the cardiac dysfunction. Some genetic issues, congenital heart disease issues, mechanical ventilation itself, because when we will discuss, we will see if you have a high intrathoracic pressures because of the mechanical ventilation, that again causes the dysfunction of the ventricles, and the pressure level itself causes the dysfunction of LV separately and RV separately. So it's altogether a big lecture in itself, that how the increased PIP and PEEP can help cardiac contractility, and after some limit, when it increases the limit, is become a detrimental for the cardiac contractility. Hypovolemia, as in case of IVH in the preterms, is another cause for this shock. And adrenal efficiency, as they are corticolamine depleted, especially the preterms, is one of the reason for poor cardiac outputs and cardiac contractility. So these are the few major issues. So once we try to get the perception, try to assess these cardiac issues and the causes of the shock, it will be a good thing to know cause, then the pathophysiology, and then to appropriately treat the babies. So that is very important. So that's why two things are very important to know and assess. One, pathophysiology, and know the cause, so that you can treat. So this is something graphically the same thing what we have discussed. I'm just presenting. This is the heart, this is the tissue. So this vessels after the heart and before the tissues, they will cause the afterload. Okay, from the tissue towards the heart, from where the blood flows to the heart, that acts as a substrate. This is your preload. So what happens in hypovolemia? Overall, the intravascular volume is low. Okay, even though the heart is contracting normally, but because of the hypovolemia, low substrate, your tissues are less perfused. If there is a cardiogenic shock, means cardiac pumping is affected. So what happens? The whole substrate, the blood, will keep on accumulating here. So it's a cardiogenic shock. So the afterload, even though it is being normal or whatever, will have a low cardiac output and poor tissue perfusion because the heart is not pumping the blood appropriately, and the whole blood is getting stasis before the heart. Okay. So what is this? This is, you don't have the money. Even my wife is good. I am able to spend. I have no money to spend. Here, my wife is good. I have the money, but I'm not able to spend. Now, septic shock, what we call as the mixed shock. In this, what happens is there is peripheral vasodilatation. The stasis of the blood occurs. Okay. So what we have done, we do have the money, but we have put it in the FD. So that money has gone into the fixed deposit. So it is not available to be spent. So it is there in the vascular, intravascular stasis is there. The next thing is heart is not pumping properly. So less substrate, less pumping of the heart, and is not able to pump out appropriately. So that is your septic shock or a mixed shock. So now we come down to the basics of the pathophysiology, what we have discussed in terms of preload, afterload, and the cardiac contractility. See, whenever now we talk about our shock, so the first thing that struck us every time is the blood pressure, because that is something very commonly we measure in the newborns or pediatric patient or the adult patient, and then we try to correlate with the shock. So that's why it will be easy for us from the clinical point of view if we try to explain it by the blood pressure. See, previously, like many years back, we used to correlate the blood pressure and the shock together, and we used to represent shock as blood pressure. Then with all the pathophysiological knowledge and research and evidence, we come to know that blood pressure is not very useful, and the amount of evidence that correlates with that, I will show you the slides regarding that. So then we thought the cardiac output is something which is very important, and this is something we should care about. So then we shift our attention from blood pressure to the cardiac outputs. And now we know that the cardiac output is not everything, because of the end result is the normal cellular metabolism. That should be taken care of. So that's why they are the part of that, but the final outcome, final result should be the normal cellular metabolism. So let's start with the blood pressure. What we always think is the thing. So the blood pressure is a product of SVR and the cardiac output. So here, both these things have been involved, cardiac output and systemic vascular resistance. So now, if the compensation is going on and the patient is in shock, when the patient is in shock, in this statement, what is there in front of you? What if your blood pressures are normal and the perfusion is poor? The baby is in shock. Okay, your blood pressures are normal. Okay, if the baby is in shock, what will decrease out of these two? SVR and cardiac output. What will decrease? Anyone? You can write down in the chat box or you can unmute and talk. Cardiac output, yes. So your cardiac output will decrease, but your blood pressures are normal. So that means your body has compensated through how your body has compensated. Anyone? You can write down in the chat box. Yes. SVR increases. Yes. Great. So if your blood pressure is maintained, your cardiac output is going down because you're going into shock. So what the body does, it increases your vascular resistance to maintain the blood pressure. Okay, so that is what we used to call as the compensated shock, which is now we don't use that. So this is what I was trying to tell you, that in the newborn, especially in the preterm baby, your compensation by the vascular tonicity is very poor. So they don't compensate by increasing the vascular resistance. This is more pronounced in the bigger pediatric patient or in the adult patient. Okay, great. Now, we were talking about cellular metabolism. So your cellular metabolism basically is by the perfusion, good perfusion of the blood. That is being achieved by cardiac output and the oxygen content in the blood. Oxygen content, everybody knows, depends on your hemoglobin and your lung disease and the cardiac shuntings and the hypoxia, all those things. So that will take care of your blood oxygen content. So now we are, for proper cellular metabolism, we are left with that there should be a proper cardiac output. Okay. So cardiac output, now when we talk about cardiac output, as somebody initially only told, is a product of stroke volume times the heart rate. Okay. And now this very important things from the point of view of newborns has come into play. This is there in front of you. So stroke volume is the amount of blood volume that is pushed out of left ventricle in one contraction. Amount of blood pushed out of LV in one contraction times the heart rate. So in newborns, what happens is as we have discussed, the SVR is something which is not used much, which is of no much value in, especially in the preterm, because their capacity to increase or decrease the vascular resistance, that compensatory mechanism is not well established in the newborns, especially in the preterms. The compensatory mechanism that is well established in the preterms of the newborns is they can increase and decrease the heart rate. So that's how they try to maintain the cardiac output, by increasing and decreasing the heart rate if your stroke volumes are going down. And we have discussed, so that's why instead of SVR in the newborns, heart rate is something that plays a major role in compensation or maintaining of your cardiac outputs. So that's why we have taken off SVR and put heart rate in the newborns. And these three things remains the same in all the age group: afterload, preload, contractility, and the heart rate. And they are all interdependent on each other, as you can see. Afterload, as we have discussed, is controlled by systemic vascular resistance. Then any vasopressors we start, or if there is any anatomical obstructive lesion, that affects your afterload. Preload is by your intravascular volume. And then by increased intrathoracic pressures or if there is any major effusion, pericardial effusion. That affects your preload and its effect on the cardiac contractility. Your cardiac contractility per se, as we have discussed, it depends on if you have a severe acidosis, the amount of catecholamines, and the ventilatory settings you have, as we have discussed initially also. So your ventilatory settings does affect your cardiac contractility if they are very high range, especially in the preterm babies. So I will like to try the same thing. I will like to try to explain to you. This is a preload. Is less hypovolemia, third spacing that occurs. As I told you, if your money is there in the bank, but they are in fixed deposit, FD. So they are not available to you to be spent. They are parked in some place. So that is your vasodilatation. So they are parked there. It's not, that substance is not available to be pushed into this pumping heart. Cardiac, when we will talk about the indices for the cardiac contractility, we will learn about fraction shortening, EF, and all those things. If it is normal, your preload is not there, it will not be able to give out the good cardiac output. Okay, your afterload may be normal or low, output will be low, even though your afterload is low or normal, and your cardiac contractility is normal if your preload is less. So that's why you need a, so what we do, we increase the fluid, pushing the fluid. Okay, cardiac contractility is normal, then your output become normal. So we have pushed in the fluid, already the heart is contracting normally, and that the same cardiac output will increase. So that's how you tend to treat your low preload or hypovolemic shock. Okay, this is one way we have understood the pathophysiology and we have treated that pathophysiology. Now the next thing is, in hypovolemic shock, I have just explained to you. Now the next thing is, so we have talked about hypovolemia, the preload. Next thing is your cardiogenic shock. Your pump has failed. Okay, in that, even you have a normal preload, if your pump has failed, your output will decrease. It will not be normal, it will be decreased because your heart is not able to pump the appropriate amount of blood that is coming to it. Inotropes we will discuss later on when we will discuss management. Then your heart is able to pump normally, but you may have an anatomical obstruction like hypoplastic left heart or aortic stenosis or coarctation of aorta or interrupted aortic arch. All these things, if you have, then none of the drug will act on your contractility because there is some anatomical physical obstruction is there. So in that case, you have to relieve that obstruction, and the immediate thing what you can do, if you have anatomical obstruction in the left outflow tract, what is immediate thing you would like to do in that case? Anyone? You can write down in the chat box. Or you can unmute and talk. What will be the drug of choice to treat that case? Somebody has written, let's see. Yes, prostaglandins. You would like to open up the duct so that your systemic flow should continue with the, it bypasses and it comes through the duct and then system gets perfused. Okay, so that is something which we need to know. So now, whenever we talk about pathophysiology, we need to assess, and when we'll talk about the echo indices for the shock, we will be assessing the situation the same way like we did in like the PDA sessions we have finished. In PDA, we assessed pulmonary overcirculation, systemic hypoperfusion. Similarly, in echo-wise and clinical, we will assess preload, cardiac contractility, and afterload. Because where is the defect, their place we should treat that particular part, particular issue that we are encountering. So that's why Now we always try to segregate our cardiac shock issues in three compartments: preload, cardiac contractility, and the afterload. So then comes this mixed shock. And as has been seen, the arrows are on all three. So mixed shock is a septic shock, is the most common reason for that. It can cause peripheral vasodilation and hence cause hypovolemia, artificial hypovolemia, can affect the myocardial contractility. And how I'm like, I'm pointing this arrow towards the afterload increase and decrease, because in the initial phase, especially in the term babies and in BLWs also, there is peripheral vasoconstriction. The shock causes initial septic shock, causes initial afterload also, and hence your myocardium, which is affected, is not able to pump out the blood to the increased afterload, and hence your cardiac output or the tissue perfusion decreases. So sepsis is something which can hit at any of this point, and hence you may have issues in preload, contractility, and afterload with the septic shock. So till now, we have talked about the pathophysiology, causes of the shock, and we have segregated the assessment, treatment, indices of the shock under three headings: preload, cardiac contractility, and the afterload. Okay, so that is for clinical judgment also and by the echo also. So if I want someone to assess the shock and manage the shock, the first thing that person should know is how to recognize a shock. That person should recognize that this patient is in shock. Next step comes that we should be able to determine the severity, how severe is the shock, so that what action needs to be taken, how quickly it has to be taken, is to be assessed. Then comes the etiology. What is the etiology behind this shock? Until unless we know the etiology, it will not be appropriate to treat the shock with a blanket therapy. Therefore, we would evaluate and then plan the treatment. For that, we need clinical assessment, vital assessment, investigations we need to do, and then the functional echo. The echo to assess whether what we have assessed clinically is what we are dealing with, whether the issue is in the preload, in the cardiac contractility, or in the afterload. So that's why it has become an important part of a kind of investigation for the shock. This we have already discussed. Sorry, laptop. Okay, so now let's discuss one scenario. The 26 weeks, birth weight 810 grams, born to primary by normal vaginal delivery, cried immediately, no antenatal issues, but there is an RDI. Baby when born is a respiratory distress syndrome. Even though the baby is full steroid covered, delivery room CPAP was started and was shifted to NICU on CPAP. In NICU, the baby is being continued on CPAP of 6 centimeter FiO2 of 40%. The vitals, heart rate is 165, SpO2 92% in the right arm. Invasive blood pressure monitoring has been done. So this blood pressure is systolic 48, diastolic 28, mean of 29. So is this mean of blood pressure 29 appropriate for this baby at this gestation and day of life? Your comments?
Yes.
Yes. Okay. Because this is something we always consider, that the mean blood pressure is same as your gestation age. Just a second. Okay, sorry. So that is something. The mean blood pressures is same as. So CFT is being prolonged 4 seconds. So this baby started having desaturations and developed mottling and became off colored. So what are the reasons for the deterioration? Okay, pneumothorax, yes, can be. Anything else?
PDA,
Pardon?
PDA,
PDA, yes.
shock,
PDA, sepsis, yes. Pneumothorax, PDA, sepsis, shock, yes. Great. So dope is because this baby is on CPAP. Any baby on positive pressure ventilation, like ventilation or CPAP, we need to rule out dope first. It can be worsening HMD. The shock can be because sepsis, IVH. Because of IVH, you will have hypovolemia and the hypovolemic shock. Okay. Yes. Great. So pneumothorax, dope, worsening of the HMD, IVH, shock, IVH, everything is ruled out, but still the perfusion is poor. Okay. So we will come down to the cause again. So now still the perfusion is poor and pneumothorax and IVH and HMD worsening, everything is being ruled out. Next thing is we have assessed, we were not able to know what is the major cause, but along that we have to treat this baby. So will you give bolus if you want to manage this baby? Will you give bolus? Yes. Then how much? If no, then why?
10 ml per kg.
10 ml per kg. Okay. Yeah, it can be CHDs. Yes. Okay. So anybody who doesn't want to give the bolus? And if you don't want to give bolus, why you don't want to give bolus? Those who don't want to give bolus can very well be correct. It's not an issue. But if they don't want to give bolus, why they don't want to give bolus? Cardiac failure, okay. See, in this, especially in the ELWs, if you give sudden boluses or some boluses you give, if the baby does not fit into that category, may cause IVH. Yes, very nice. So it may cause IVH, and as Dr. Shreja has written, need to check the intravascular volume whether it is needed or not. Okay, but most of us, what we do until it is documented in hypovolemia, there is a loss, sway loss of blood. For any cause of the shock, we give we give 10 ml of per kg of bolus slowly IV. Okay, so we gave the bolus, but the baby did not improve. So what will be our next step? Yeah, okay. Echo is something should ideally we would have done, but still we don't have the access to it. Inotropes, yes. See, clinically, if we treat the shock, the thing is, if we give the bolus, the next step naturally will come down to the inotropes. So the next question will be, we don't know the cause for this. We have given the bolus, still the perfusion is poor. So we have now have to decide the inotrope. Which inotrope I should give? What is your choice out of these four in this baby? Adrenaline, dopamine, dobutamine. Till now, I have got four answers, and in all the four, except for milrinone, all the choices are there. Dobutamine is predominant. Adrenaline in one, dopamine in one. Okay, we'll come down to this case again. Good. So this is how the confusion starts. Even you get confused which inotrope I should be using because I don't know the pathophysiology. Until unless I know the pathophysiology, I will not be able to treat that. So that's why we always press on look for the cause, look for the pathophysiology, and we will discuss that. So before going ahead, one thing in pathophysiology, especially in the ELBWs, that how the postnatal adaptation occurs in these ELBWs, we should understand. Then only we will be able to pinpoint the cause and treat that thing. So in the first 12 to 24 hours when the baby is born, so what happens at the birth? The cord is being clamped and hence your baby is separated. So when the cord is being clamped, when the baby is separated from the placenta, your LV is previously, when the cord was intact, was exposed to placental circulation, which is a low resistance circulation. As soon as your placenta cord is being clamped, your LV is exposed to the high resistance circulation, that is your systemic vascular resistance, because the SVR is much higher than the resistance in the placental circulation. Then that means the afterload to the LV, to which the LV was exposed in the fetal life, has now gone up. Okay, so therefore your LV needs to develop the output to work against that resistance which the LV was doing intrauterine. So that is one thing. The other thing is your LV is adapting. It's, as I told you, in the preterm babies, if the myocardium is weak, there is inherent diastolic dysfunction in the myocardium. Hence, your functioning is decreased. LV function is decreased. So that's why it has to work against increased afterload with inherent dysfunction of the myocardium. Okay, so that is happening. So now there are two things which are happening after, within 12 to 24 hours after the cord is clamped. Okay, now the next thing is the PDA is already there. So because of the RDS and prematurity, what we do most commonly, we give surfactant. When we give surfactant, what happens? If the PDA is being there, there is left to right shunting which increases. With the increase in left to right shunting, what happens to LV? What happens to LV if your left to right shunting increases through the PDA after giving surfactant? Anyone? You can write down in the chat box. Okay. So the left to right shunting, there is a volume overload. Okay. So now see what happens is your LV after the cord clamping has been exposed to high pressures. LV itself is not functioning normally because of decreased functioning of LV and is exposed to high pressures. And then because we have given surfactant and the PDA becomes HS hemodynamically significant, there will be volume overload. Therefore, the LV now has to pump out more amount of blood with all these things. Okay. Therefore, there will be a systemic hypoperfusion because shunting of the blood and decrease blood coming out of LV. More preterm is the baby, higher are the chances, higher is the pronounced is the effect what we have discussed. Because the systemic hyperperfusion takes place, the less amount of blood also goes to the brain during this period. Okay, this we can very well document through the SVC flows. So while this, within this time period, okay, within this time period, your adaptation is going on. So the baby, by within this time, your LV adapts. So when your LV adapts, recovery take place, and hence your low cerebral blood perfusion becomes normal. But that is what we call as reperfusion, and hence it can end up having IVH. That's why the first 24 to 48 hours are known as the honeymoon period in ELBWs. And after 24 to 48 hours, when this reperfusion injury occurs, that causes the increased risk of IVH. And these are the things: 1, 2, 3. These 3 things are the cause for the poor perfusion in these ELBW babies. 1, 2, and 3. And then when after recovery, when reperfusion occurs, is the cause for IVH. These 3 things cause for the poor perfusion or the shock in ELBWs. Recovery and reperfusion is the cause for IVH. So that's why this slide is very important to understand that what causes the IVH at 24 to 48 hours and what are the causes of initial causes of poor perfusion in ELBWs. So that case of ours, this thing explains that. So now see, this is your LV, aorta. If the PDA is open, then through aorta and PDA, your LV is exposed to pulmonary vascular resistance and SVR, systemic vascular resistance both. Okay. Now see, what you have done is, if you caused because of hyperventilation, you caused hypocapnia, you given O2, or in severe cases in term, you have given nitric oxide. So alkalosis, what it causes, what it will do, all these conditions, what they do, anyone can write in the chat box or unmute. Yeah, it will cause decreased pulmonary vascular resistance. Okay. And vasopressors, hypoxia and hypothermia, what it does, well, this is what happens normally in the when the preterms are born and you're taking care of those preterms. What these 3 things will cause?
Reduce systemic vascular resistance.
Yes, so it will increase your systemic vascular resistance. So if you have caused decreased pulmonary vascular resistance and increased systemic vascular resistance, and the PDA is open, the blood will go preferably towards the low pressure side, that is towards the lung, then towards the system. Your systemic perfusion will decrease and pulmonary perfusion will increase. So that will cause, that's how your HSPDA works also. Okay. So that is the issue. So that is the whole pathophysiology we have discussed till now: preload, cardiac contractility, afterload, and what are the issues that happens in the ELBWs, so that we should understand these conditions and hence we will choose our treatment appropriately in those conditions. So let us discuss one another scenario. Preterm 34 weeks, 1.7 kg, gravida 1, cried immediately, no antenatal issues, insure was been done on high flow nasal cannula. Day 7, there is sudden deterioration, poor perfusion and the shock. So causes can be many. What can be the causes in this patient? Causes for shock, day 7, 1.7, 34 weeker. Anyone?
Sepsis.
Yeah, sepsis, yes, most common. PDA, sepsis, yes, these are the most common ones. Okay, so that we know. But now, if I ask, like, especially it will be useful for residents or neonatal trainees, if they are there. The clinical assessment is as or more important, I would say, than your echo assessment. So that's why we should be able to assess the shock, the severity of the shock on the basis of clinical assessment and on the basis of normal vital measurements what we do. So that's why we always do that. And when we say that clinically how we assess the shock is basically by the blood pressures. Nowadays we use these normograms, but normally what we do is our mean blood pressures is same as the gestation. And you know from where that thing came into existence? By this paper in Archive of Disease of Childhood. And 20 pediatricians they sat in a bar in London. Out of 22 were neonatologists, practicing neonatologists, and they discussed that we don't have the normal values for the blood pressures in the newborns. There they decided that the mean blood pressure will be same as the gestation age, and that will be your mean blood pressures for that appropriate for that gestation age. And then since then, this has been stringently followed. I don't know, it can be true because they were sitting in the bar having something which always compel humans to speak truth. So that has become the what I would say the God's word, word of the God. And then this is what we've been following that. But actually, when we do and match that with the cardiac output, SVC flows, the sensitivity and specificity is very low. So that means whatever non-visible blood pressure monitoring we have been doing is not very appropriate. But still, it is a part of the assessment. So we do the blood pressure monitoring. Okay. How we do the blood pressure monitoring, how we do the vitals, we will discuss. I would skip this thing for the time being. We will discuss when we'll discuss for this thing, management. So when we talk about the diagnostic approach, okay, how we assess clinically, so it should include the whole, the history, vitals, examination, investigations. So there are different these sections for this shock assessment and management. Today in this section we have talked about pathophysiology. So this diagnostic approach and this thing we will cover up in the next this thing. So I just wanted kind of give you an outline that what we will be doing in the next session, okay, and how we approach history and vitals, what we do, investigations and all that we will discuss. And then we'll go on to eco, and then finally we will discuss and have panels or debates that which inotrope is to be used when and how is to be used. But everything will be based on what we have discussed today, that is your pathophysiology. So thank you very much, everyone, for participating. And if you have been interested in knowing more about neonatal hemodynamics and eco and point of care and POCUS, these are the few books that we have published, are available. You can write down on this email. And if you're interested in doing short courses, 2 months, 3-month course, or 6 months course, you can write us on this, or you can WhatsApp me. Thank you very much.
Thank you, Mohit sir. Excellent talk. And I think these basics are very important before we just move ahead to learn the echo and its applications. So this clarity was very much needed before we understand the subject. I request if anyone has any questions. You can put in the chat box or you can directly ask.
I could see a few of the faces. They have even joined from Bangladesh. So it's really encouraging to see them. Recently, I was in Bangladesh for conducting their first eco workshop in Dhaka. So it was a good group there. We have Dr. Manan there. He is the secretary for Bangladesh Perinatal Society, very senior neonatologist in Bangladesh. So
Nice
we
to
are
see
very
you. Nice to see you.
Thank you, sir. Thanks for joining in. We have Dr. Shwetal Bhatt. She is our president for Gujarat State NNF. So we are
Thank you,
really
sir.
lucky to have.
Hello, sir. It's really great to have Mohit sir and because of him, participants across the globe are joining this our academic session. Thank you so much for joining.
So he is global person now.
Yes, and that's a pride for us.
Yes, and he delivered so nice talk in our conference. And also he conducted a wonderful workshop on functional echo. And our doctors are now just waiting to do the further steps, how to go the full course, I mean the virtual course and also the in person. So we are very much grateful to Dr. Mohit and his team as well. Thank you. Thank you very much.
Great.
Thank you, sir.
Great, sir. Thank you so much, sir. So I think, Urvi, we can conclude the session.
Yes, ma'am. I think there are no questions because
Yes,
sir
yes.
is so clear and crisp. I think
Yes,
everyone's concepts are clear. Yes.
Thank you, thank you.
Yeah.
Thank you,
Once
sir.
Yeah,
Thank you very
once again,
much.
thank you,
Bye.
sir, and thank you all participants for joining and in this event. Thank you, Shwetal madam. Good day to all.
Thank
Bye.
you, Vishal, for joining with us. We have our EB members in the group. Thank you.
Thank you, sir. I'm from Indonesia, Tina.
Yeah, hi, Dr. Dana.
Hi, thank you very much, sir.
Thank you.
Hello. Hello, ma'am.
Hello.
Thanks a lot for joining our session. Thank you.
Thank you very much.
So thank you, everyone. We are concluding the session over here. Thank you.